A lot of times I'll talk about sleep hygiene too. These kids are all going to bed with 50 stuffed animals and blankets in their bed. And I'll bring that up and I'm like, those are harbingers of dust mites. And they're like, oh, we already tested her for dust. Don't worry, she's not allergic. And I'm like, you don't have to be allergic to have a problem with dust mites. It's stuff that never gets cleaned, stuffed animals, and it's sitting there, so even if you can't get the expansion, let's make sure we're doing everything possible for nasal hygiene.
Hi, and welcome to episode 347 of the Untethered podcast. Today we have Dr. Anita Gouri joining us. Dr. Anita is a board-certified pediatric dentist and owner of Lafayette Pediatric Dentistry. She's been in practice for nearly 16 years and is a Louisiana native. She and her husband, Brian, have 2 daughters. In 2016, Dr. Gouri decided to pursue extra training in tongue ties and airway as a result of her own daughter's difficulties with eating and sleeping as an infant and toddler. She received her TOTS training and laser certification in 2017 and became an ambassador of the Breathe Institute in 2020. Dr. Gouri is one of Louisiana's preferred providers for diagnosis and treatment of oral ties from infancy through adulthood. So to aid in proper feeding, speech, and breathing, Dr. Gouri has pursued her passion of helping ensure children's facial growth is harmonious with proper nasal breathing, oromotor control, and airway development. She's been an invited speaker locally, regionally, and nationally, presenting education on the importance of identifying tongue ties as well as speech, feeding, and breathing problems early. Welcome to the Untethered podcast. I am your host, Hallie Bulkin. I'm a certified myofunctional therapist, feeding specialist, podcaster, business owner, and mentor. This podcast is all about getting your questions answered and collaborating with colleagues to bring you the most up-to-date information in the orofacial myofunctional therapy, airway, tethered oral tissue, and pediatric feeding therapy space. If you're new here, I challenge you to keep an open mind and join my mission to spread this message far and wide. If you've been around since June 2019, thanks for being a loyal listener. As we jump into today's episode, remember to listen with correct oral rest posture. Tongue up, lips closed, teeth apart, breathe through your nose. Let's get started. Anita, welcome to the podcast.
Hi, thank you for having me.
I'm excited to have you join us today. You're very important in our world because I know you work with, you've helped one of our near and dear team members and with her kids. So I would love for you, before we jump in, to just share a little bit about how you got into the airway, tethered oral tissue focused space.
Sounds good. I am a pediatric dentist, and so I'm in the oral cavity already, but they don't really educate. At least I graduated in 2008 from residency. Back then, there was not a lot of talk about airway. And my daughter was born in 2010, and she had trouble latching onto the breast. She even had trouble bottle feeding, constantly having colic, gas, spitting up, throwing up. It got a little better when she transitioned to solid foods, but she could never eat anything that wasn't pureed until well past the age of 2 years old. So I just felt like, and nobody could ever tell me what was wrong. As long as she's gaining weight, this, that, and the other, it was fine. And I was grateful for that. But it had always remained a mystery to me. And then around the age when she was 7 years old, my nephew was diagnosed with the tongue tie, and he had been having all of the exact same issues that my daughter had 7 years earlier. And so I started immediately researching, going down the rabbit hole of all this kind of stuff. And my nephew was living in Virginia at the time and went to a release provider there who actually happened to be my chief resident at Children's Hospital in DC, where I did my residency. And I started talking to her about it and went home that day, looked under my daughter's mouth, and boom, there was her tongue tie. So from there came everything else, not just the eating and the latching, but airway, speech, everything. And since then, a big part of my practice has been devoted to that, not just releasing tongue ties, but referring appropriately for early palatal expansion, making sure we avoid orthodontic extractions if like at all costs, if we possibly can, things like that, and looking for sleep apnea, early signs of sleep disordered breathing. And I'm even getting adult patients now in my pediatric practice for this. And so it's really been a passion of mine for personal reasons, but also because unfortunately not a lot of people are on board with this yet. And so here we are.
Here we are. So I always love to ask about that because I feel like I'm not a pediatric dentist, I'm a feeding therapist, but I lived a very parallel,
Absolutely.
experience,
Absolutely.
And so it was really, I always tell everyone, I was working with toddlers with feeding, and then I had my child and she threw me into infant feeding, and then I went to Mayo and I came home, she was 24 months old. I flipped her over, I looked under her tongue and I was like, there it is.
Yeah.
It was painful for 13 months and no wonder she got super picky at 15 months of age, was eating everything before that. And, it was
Absolutely.
just very eye opening. And again, there were just not enough providers that could help me,
Right.
my own child. And I felt like, okay, well, I am the provider and I
Yeah.
should be able to help my own kid.
We're going to do this. Right.
Right, right. Fast forward, she's now 2.5. I have a baby. That one, that child's born with a tongue tie. She went at day 5 and had her tongue tie released. Very different feeding experience. We dealt with some other things. She's now had 2 rounds of expansion. My older one is now 10 and has had 3 rounds, and they're actually getting their final expanders out tomorrow. So they're very excited. But so it's really opened up my eyes to this airway world and
Yes.
the oral tissue world. And, to the point where as a pediatric feeding therapist and myofunctional therapist, I was like, I don't even feel like I got that education post grad school. That I had to seek it out. And even in my feeding courses, nobody's talking about this.
Yeah.
And so I created it. But, to that same token, I'm like, it's because my own child was such a good educator and really threw me down this rabbit hole that I also then went like, well, I had braces and expansion as a kid, but clearly I need more. So I had an adult tongue tie release, and I had, I have Vivos DNA appliance, which gave me a little bit of teeth, I think, expansion, tooth-borne expansion, not necessarily through palatal expansion, but now I'm in a MARPE. So there's that.
There you go.
It's been like a whole whirlwind, because like you said, like this is just not something that's traditionally taught. It's still not being taught in our graduate programs. So yeah. And here we are.
Right.
Here we are.
Preaching to the choir.
Yeah,
Right.
right. So from your perspective as a pediatric dentist, right, in this space, do you feel it's important for children to be seeing pediatric therapists, whether it's an SLP or OT or an IBCLC, somebody that can work with them in collaboration with you, especially if you're going to be doing like a
100%.
release, for example?
100%. I prefer them to come to start there. Um, a lot of people hear that I do tongue ties and just immediately refer to me, but I'll actually tell these people actually you should send them to a therapist first. And it's a lot of, back and forth on that because they see therapy and they see me as a quick fix, and never the twain shall meet sometimes. So it's been a big battle in education on my part, but always I want them to start seeing IBCLC, pediatric therapist, OT, speech therapist, whichever angle first, because it's so much better for the outcome if they indeed have a tongue tie that needs to be released.
Yeah, I
For
love
sure.
it. That's music to my heart.
Yeah.
I admittedly, as a therapist, even who got into this space in the very beginning, didn't understand the importance of like the
Sure.
we're sending for a release. And it wasn't until we kind of updated our protocol. We were collaborating with a lot of pediatric dentists. Everyone had different ways of doing things, but the one
Yeah.
is required that they have us sign off that the child was ready, that they've gone through therapy, they've kind of gotten to a certain point. And then we had these kids come back to us after the release. We were like, oh my gosh, these children are responding so much better than the kids who are just coming for post-op therapy and who didn't have the pre-op therapy. And that was a whole big eye-opening experience for me.
Yes.
So what are your thoughts then on, not just the pre-op, but then the post-op intervention as well?
Oh gosh, I see it all the time. I see higher chances of reattachment or no reattachment, but that tension is still there. We're still battling. The symptoms aren't resolving. And, every parent I see, I tell them this is what's optimal for your baby. But I'm going to be honest, access to care is not there in our community for Medicaid. There's very few providers and there's a wait list. And access to care is simply not there because they're single moms and they're going back to work, and you still want to remove that obstacle. So it's a lot. There's a lot of gray area. But I absolutely I'm in the position many times where I see like, oh, I wish we were able to get in with that therapist beforehand. And if we lived in an ideal world, that's how we do this.
Yeah, I
So
was just talking to another provider and we were talking about textbook and ideal and then real life, and how,
correct.
yes, we
Correct.
might suggest one thing, but also like we will meet you where you're
Yep.
at. And as
Yep.
long as it's going to be beneficial, we believe it'll be beneficial
Yep.
for you and your child,
And
we will work.
unfortunately, even people that do have access to everything, if their pediatrician is not on board with this, which unfortunately many of them are not, they won't even sign off on the therapy orders. But insurance companies require a medical doctor to sign up. It's not okay for me to sign off. So there's a lot of barriers, unfortunately. But yes, absolutely, pre work is 1,000 times better for everybody involved.
Yeah. And that's that's a world I feel like where I personally don't have a lot of experience in, because we have a private pay, private practice, and I live, not I live, but my practice exists in the Maryland,
Yeah,
DC, Virginia
sure.
area, where there's literally a practice on every corner. So like we can get away with that. There are practices that take insurance. We do not. And so thankfully we don't have to wait for someone to sign off technically, right, for
Right.
insurance reimbursement. And
Right.
in some cases, private insurance will reimburse without that, as long as they have a report from us or the dentist has signed something. But it's so unfortunate that it's still so highly dependent on providers who don't get it. And
I know.
and that that's the thing standing between children getting, the ideal.
Life-saving care. Yeah. Yeah. Absolutely.
Yeah.
Life-changing care, rather. So, yeah.
Yeah.
I agree.
That's fascinating to me. One of the things that I set out on when I created my current online business, because I have an online continuing ed company, was, I want to get these children off of pediatric feeding wait lists. That is my
Yes.
main mission and everything that I do, which is why I train SLPs and OTs. We talk about tongue tie, TOTS, myo, airway, all the things as it relates to pediatric feeding, and then try to bring people in to communicate about all the related therapies and topics and everything. But, even though we've trained now 2,600 SLPs and OTs in the past 5 years, but there's still wait lists. It's like, I just go back to, can we
Yep.
get these kids, like no child should have to wait for
100%.
therapy that they absolutely need, right? It's not like,
Yeah.
oh, this would be a nice to have. No, this is a necessity.
Yeah.
So we
There's
still
also a lot of variability with the therapists that are available too. So it's so hit or miss sometimes too. So yeah.
yes, I hear you. And there's a very interesting divide, even within the SLP community, where there's still a large
Yes.
number of SLPs who don't believe tongue ties are real,
Correct.
that only believe tongue ties should be addressed in breastfeeding infants. Or
Correct.
I'm like, where do we get these it's just, yeah.
And no home exercises are given, and different things like that. So it's just, the parents will do everything right, and then still
Yeah.
there's a barrier there. So yeah, it's
Yeah.
tough. Hmm.
And then in the older kids, so I know we briefly were reviewing some talking points before we hit record. And, I know you're a believer in getting an airway evaluation before putting children
Yep.
on ADHD meds, which I am a big proponent for. So
Yeah.
can we talk a little bit about that?
Right. That's also another barrier. There's only a few ENTs that are willing to do it, but yes, we are big believers. And I definitely, we look for tongue ties, we look for tonsils, we do all the other things on our own, but sometimes there's nothing there that's obvious that we can see, but you can tell this person is suffering. And so there are a couple of ENTs in the area that we do work with, that it's been life changing for some of these kids.
Yeah.
So
Do you find that these children are going to like psychologists or psychiatrists that are putting them on medications and they haven't had the proper airway?
yeah, 100%.
Yeah.
That's in the majority of cases, actually.
Yeah.
Yeah.
And it feels
Much like much like they come to me for the quick snip, the quick
like,
laser, because they just think it's the quick, let's try this first, kind of thing.
interesting.
So yeah, it should be the other way around, right? But
Yes. Yes. Well, and it's kind of, going against the grain. This has been the
right.
traditional way that we've done things now for however
Yeah.
many decades, and someone is saying something different. And, I always like to show parents, not that their child is at this level, but like the Finding Connor Deegan video.
Yes, that video.
And, I think when a lot of parents see that, they're like, oh my gosh, like their eyes are just open. And if we can empower the parents, sometimes we can get them to advocate. And they're like, I
Correct.
will not settle for anything less than,
Right.
but it's unfortunate because not every parent has the opportunity to
Yep.
get that education or has the capacity to advocate full time for their child
Right.
in the way that their child needs in the current landscape of medicine. So
Yes, that's really what it is. It's the barrier,
yeah,
that you
yeah,
fight through.
lots of barriers, unfortunately.
Uh-huh.
And then to that point, it's also encouraging parents to trust their gut. Because like I know as a mom, like I knew when something was off, but even as a professional, like in this space, I was like, I don't know exactly what's off. I just know something is off. Something's not right now. I went and got the education and was able to do that.
Right.
But, it's like sensing like if something is wrong, your baby's not feeding well, they're not sleeping well, there's something, behavior, whatever. I think giving parents permission to seek the help that they want and not just settle if they feel like what's been provided to them as an intervention is what feels right for them. I've had a lot of conversations with parents about just trusting their gut and pushing for more.
Right. I agree. I agree. I definitely tell people to share their story,
Yeah.
especially if they came from a provider who was kind of anti, so I think moms advocating for themselves are also advocating for people who are silent, silently suffering. So
Yeah.
sharing their story is crucial for sure. Yeah.
Yeah. No, that's a really good like
Yeah.
perspective on this is like if you can speak up and if you want to speak up and this gives you the encouragement to speak up, you are
100%.
probably also helping those others who are either
Correct.
unable to or unaware or they just
Yes.
like this isn't my place or whatever the case may be.
Exactly.
I hadn't really
Exactly.
looked at it through that lens before, so I really love that because it's like
Yeah.
giving somebody else a voice.
Absolutely. Absolutely. So, yeah.
Yeah. So, okay, let's talk about some more of the airway things. So if someone is newer to airway, are there certain like signs or symptoms that you tell parents to look out for? Obviously mouth breathing, etc. What is it that you usually educate them on?
The big one that they don't realize they should, other than mouth breathing, that they don't realize that they should be looking for is the hyperextension of the neck when they're sleeping.
Mhm.
A lot of parents just think it's kind of cute. Like, oh, look at they're all thrown back there in deep sleep and their mouth's hanging open. And those of us who know are like, "Ugh," kind of a red flag. And they're always sleeping like that, as well as just the constant tossing, turning, restless sleeping, making a little clock around their bed, which is another thing my daughter did until she had her palatal expansion. Um, I feel like the conversation needs to start early in the medical field about this kind of like signs and symptoms to look out for. Um, the sleep. I feel like it starts with sleep, and then it goes forward from there. Because with kids, I feel like that's where you notice the signs the most. So certainly people are mouth breathing throughout the day and all that too, but you'll see the breath holding, moving all around, hyperextension of the neck. A lot of people think I've noticed this. A lot of people think the breath holding where they is just normal sleep pattern, or they're just in really deep sleep right now. That's how I know they sleep good.
Mm,
I've heard that. So, a lot of changing of perspective kind of thing, which you have to plant the seed too. It can be very overwhelming. So we just kind of have like a little list. I'm like, oh, kind of look out for these things. And it may be nothing, but it's just always, we always want to be aware of how often it's happening and things like that. So, and then, we're not sleeping with our kids in our room, many of us at certain points. So you're not even aware it's happening,
yeah.
so just observing your child's sleep
Yes.
well after bedtime, to me, it's what I always tell parents is the key. Sometimes just taking a simple video, like they say in the Breathe Institute where I trained, don't take a video of them right after they've fallen asleep. Wait an hour or two, and then go look, and it's like a different child almost. So
Yeah.
yeah.
Yeah. It is fascinating. I had one patient, the mom was worked with adults, but was a therapist. And,
Yeah.
she would say, well, I mean, my child sleeps great. Like she goes to bed and sleeps 12 hours, doesn't get up, doesn't bother us. And let me tell you, that child in preschool was snoring like
Yeah.
worse than a middle aged, like
Yep.
overweight male, right? Like, and the teachers were like, we have concerns. And
Yeah.
they pulled me in, and I was still in this preschool at that point, as a private provider going in. And so, like, I didn't really have like an agreement per se where I could just go screen any child, but they were like, hey, you're dropping this kid off. Can you just stay for a minute and like listen to this kid? And I listened and I was like, oh my gosh, this child has sleep. They sound like they have sleep apnea.
Right.
I went and I told the director, and they ended up calling the family. I was like, look, I will talk to the family for free. They want to hop on the phone. I would like the child to go to an ENT, really.
Yeah.
Anyways, they ended up rushing that child for like emergent surgery, which is not your typical case by any stretch of the imagination. They said that she was so occluded that her tonsils and adenoids, so she just couldn't breathe, like
Yeah.
at all.
Yeah.
And here these parents were thinking, like, well, my child sleeps 12 hours per night. Now, this kid was turned around at circle, didn't respond to their
Right.
name.
Like
They
they're technically asleep, but right.
like very like kind of like like loopy or kind of like out to lunch. Holy cow, like when this child had the tonsils removed and adenoids were reduced and they started to sleep, and this was again a more of an emergent case, within a week this kid was responding to their name. They were sitting face forward at circle time. It was a different kid, no
Right.
longer snoring, and the parents were just like, I had no idea.
Yeah. Why would you? Right.
No one's ever
Right.
asked me, no one's ever said anything. And I was like,
Right.
thank goodness for this child having nap time as a 3-year-old in preschool so we could identify this
Yeah.
because how scary, and so it's really it kind of begs that question of, when do you go in and listen to your child? And I love that you brought up, that the Breathe Institute mentions like an hour to 2 hours after they fall asleep, because, that gives them time to get into those deeper sleep
Right.
patterns where we probably are going to see that maybe they're not actually entering deep sleep, and maybe they're
Right.
tossing and turning and their mouth is open and you're going to hear audible breathing and all like the perfect storm, right? All
Yeah.
the things, if they're there, are probably going to
100%.
present themselves. And
Correct.
we do the same thing where we ask families, like, can you just snap like a 2-minute video of them sleeping and send it to us? And, we're able to see so much in that little snippet.
Yeah.
Yeah. It's,
Right.
yeah. And I
Right.
had, my now oldest, she's 10, but when she was an infant, and I didn't know this at the time, she used to sleep with her tush up in the air with her
Yeah.
arm
I know.
head.
It looks so cute, but
So cute, but like
yeah.
kind of tripod sleeping, obviously opening her own airway. And so
Correct. Correct.
audible breathing or anything, but she was definitely propping her airway open. And I was like, if
Yeah.
I only knew then what I know now.
I know. You just think it's something cute. And
Oh,
that's the thing, the education of it. The
yeah,
ones that always prefer sleeping on their side or tummy, is it because they don't like sleeping on their back? They can't breathe when they're on their back.
yeah.
All of that makes so much
And,
sense.
and she was a child who she was very tense as well, but she flipped herself onto her belly at 3 months of age. So that was a kid who was determined to get off of her back and,
Correct.
and open that airway. And
Airway out. Yep. Yep.
it was like, wow. Like when I
Yeah.
started to really look at it, I was like, oh my gosh, because she was not a kid who was, she got sick once in a while, but she was not a kid who had like, she wasn't snoring. She didn't
Yeah.
have infections all the time, and
Right.
so
That's
it's,
the thing. It's so variable.
yeah,
Everybody like has different things that affect them. Like my child never had a problem with speech, for example,
yeah,
but she didn't eat solid foods until she was after age two, table food. So
yeah,
it's so variable, you
yes,
know.
yes, yeah. And then there was my now youngest who had croup as an infant into her
Yeah.
3rd year. She had croup 9 times and was on a steroid 9 times. And I finally was
Oh
like,
my gosh.
something has got to give. And we moved down here to South Florida. And I was just like, okay, I need to find a holistic pediatrician. I was like, does this
Yeah.
thing exist? Let me
Yeah.
find a holistic pediatrician.
Right.
And she was just like, well, what we know is she's constantly being put on steroids, which is going to deplete her immune system. And she's going to, it's like this cycle,
Right.
right? So
Cycle.
I took it upon myself to take her for expansion at,
Yeah.
age, she was almost 4. And we went right into rapid palatal expansion because she was kind of an airway crisis kid. And I was like, we don't need a slow start. Like I
Yeah.
want to dive right in. I know this is phase 1.
Yeah.
We got multiple phases coming, but
Right.
let's just, and what do you know? We expanded her and she never caught croup again. It was like she would get a normal cold and it would go away. And, they
Yeah.
looked at her wrong or sneezed next to her. She would have croup by like 12 a.m. Like it was wild. So
Right.
anyways, I'm a big proponent for all these
Me too.
early interventions, and that's probably a good segue into like early ortho and all of that. So I'd love to hear like your perspective as a pediatric dentist
Um,
on intervening early and expanding these palates to open the airway.
Absolutely. We luckily we are very fortunate to have somebody in the area that does do early expansion. And I'm not talking about 6 years old, 7 years old. I'm talking I've even done as early as 3 or 4. And it just depends obviously on the child's ability to tolerate it. But it is surprising how many people I talk to in the orthodontic field that do not believe in early expansion unless they have a crossbite. They have to have the crossbite.
Interesting.
Um, it is interesting, but you'll look at their palate and you can barely fit your pinky finger up there, and that's the thing. I realize it could be something that's overdiagnosed and just isn't taught, but in several cases, the anatomy simply speaks for itself. So I'm always trying to get people to get this done as long as the child would be able to be compliant. And a lot of times I'll talk about sleep hygiene too. These kids are all going to bed with 50 stuffed animals and blankets in their bed. And I'll bring that up and I'm like, those are harbingers of dust mites. And they're like, oh, we already tested her for dust. Don't worry, she's not allergic. And I'm like, you don't have to be allergic to have a problem with dust mites. It's stuff that never gets cleaned, stuffed animals, and it's sitting there, so even if you can't get the expansion, let's make sure we're doing everything possible for nasal hygiene. saline sprays, all that kind of stuff, because all clearing the nasal passages as well, and so combining that with expansion whenever possible, I've seen just dramatic life changes. The allergic shiners under the eyes disappear, all of the things, sleep hygiene, mouth breathing. There are times when I've not even had to release the mild tongue tie because the expansion took care of the issues, so a lot of people like to think that I'm automatically cutting or automatically saying get your tonsils out and all this kind of stuff, but it's really so much more than that. Even your diet, your inflammatory diet, um, we live in a hard world where it's hard to eat organic farm to table food all the time. I get that, but my husband stopped snoring the minute he gave up gluten, and I never thought I'd be one of these people that said that. Ever. I was like, oh my God, these people and their gluten. And I'm not talking about celiac disease. I'm just talking about gluten sensitivity. It is a thing, So we talk a lot about diet. We talk a lot about sleep hygiene. It's all a big part of it. And sometimes when you can't get, let's say your child is really fearful and they just can't cooperate for the expansion, basic sleep hygiene and dietary changes have helped as well. So it's all kind of part of the big picture. And I feel like that is something parents feel like they can control a little more too. So yeah, there's a lot of talk about, all the things.
I love
Um,
I love that.
I'm trying to get
Oh, go ahead.
more providers to be on board with the early expansion, and some have come around. But it has been more difficult than I thought. I'll say that.
It's a very interesting space. I mean, obviously, I'm not licensed to make decisions about or provide, to the therapies that, interventions that move bone. I'm only in charge of the muscles.
Right.
But it's as a mom now who, like, I had that traditional expansion and braces, and then
Yeah.
I went into DNA Vivos, and now I'm in a MARPE with these, lower expanders, which are mostly uprighting my teeth because we know, especially as an adult, like the mandible, that's all,
Right.
what we're doing with the mandible. It's been really interesting. My orthodontist is working with pediatrics and adults. She's doing research. She's done research. She's created her own like protocol and everything. And it's been fascinating to go through it as an adult, but it's also been really interesting because my oldest had an ALF appliance when she was age 4. And that's at the point that we entered into, she about halfway through the pandemic started. So the only intervention she really had, we didn't end up doing really much body work or anything because everything was shut down. And so the really cool thing with that was, even though it was a slower expander, was that her tonsils during cold and flu season up north went from being like really enlarged and almost kissing tonsils and enlarged adenoids to everything calming down. And we have like the before and after CBCTs to see, what happened with the expansion, where she was even, I don't want to say it was a full year afterwards. I don't remember exactly when we did the follow-up CBCT. But it was a friend of mine who was using her case in her ALF, mini residency that she was doing. And it completely opened her airway. And I was like, I know we're going to need further expansion. She's only 5, but to see how well that helped her in a time where the world was like in this respiratory crisis, right?
Yeah.
I was
Yeah.
fascinating. And meanwhile, my younger one was going through croup, and she got diagnosed in the pandemic as it started in DC. We got diagnosed with viral induced asthma because she was constantly sick, and she ended up being on Flovent that summer. And I was like, this is just a kid who's constantly inflamed. Now, we had built a house where I put in all hardwood floors, no carpet. I put, and I was doing all of the nasal, they were doing nasal,
Yeah.
all the things. And I just could not keep my kids healthy. It was wild. And so anyways, fast forward, we moved to South Florida. I ended up taking them from Boca to North Miami to an Airway expansion dentist who put them both into rapid palatal expanders. They were Hyraxes with like a forward growth component on them.
Okay.
And they both had tremendous growth. That's what got Mia, my youngest one, out of like the inflammatory crisis that she was in with every, breathing, all her airway stuff. And kind of started her down a healthier path. But my older one, I think she was 6 when we went into that. And it was wild because I took her to like the 3 top orthos in Boca, and one of them supposed to be airway centric, and they did a whole airway centric evaluation. And then the treatment plan was not airway centric. And I was sitting there like, well, I, have a hard time telling an ortho that he doesn't, not going to say he doesn't know what he's doing, but like, I know I'm not paying you money to do this to my kid. There were other issues too. But anyways, So I took them. Now I'm presenting her case. It's now a year or so later, and she's coming out of expansion, and I'm presenting her case with like 2 dental colleagues, and they are like looking at me, and they're like, she's not done. Like, she needs more. And I was like, oh my gosh, I think she's gonna kill me.
Right, right,
Like, I'm here for it, but she's not gonna be happy. Anyway, so they're now with like the same orthodontist that I'm with, and they're getting their expanders out tomorrow.
right.
And they have beautiful spacing between all their baby teeth. And it was really interesting because for both of them, the first time they went into any type of expansion, their delayed, eruption or delayed, losing baby teeth started, it kicked into gear. They started to lose teeth. There was space for the adult teeth to start coming in. Everything was delayed until we started expansion in both of their cases, which was wild to me, but also
Yeah,
very much so like, oh, this makes sense.
right.
Okay. And, so anyways, long story long, they have both, my oldest has now been in 3 expanders, my youngest in 2, and we're finally, hopefully at the end of their journeys, at least for now. But they're going into clear aligners to help kind of continue to hold the expansion, guide
Yeah.
the growth and everything. And it's really cool to see how far things have come, even just in the past 5 years.
Mhm.
Yeah, I mean, when they get sick, it's easy to get them back to health. They are doing their nasal rinses every day. We've got them on probiotics. It's like
Right,
all
right.
the things.
Mhm.
But it's a lot of work, and
It's a
it
lot of work.
a lot
And
of knowledge.
the changing the conversation there too with people, we're like, it's not a quick fix. I say that from the beginning. It's a process.
Yes.
It's a quality of life changing process,
Yeah.
Yeah, that's the hard part for sure.
Yeah. Well,
And
and even understanding that your child may go into expansion now, but it's not going to be the end all be all. They may need more expansion
right,
as they grow, because
right,
I don't actually see that conversation happening too much. I get a lot
right.
of people saying, oh, early expansion, get in there now and you won't need your traditional expander and braces. And I'm
Oh,
here going like, well, hold on a second. Like, these kids are
yeah,
rapidly.
making promises. And I do think that's part of the argument some orthodontists have against early expansion is that you're just going to need it again. But like you said, there's a quality of life change that needs to happen right now, you know. So it's kind
And
of
you
I
can
get where they're coming from, but
you
yeah,
can have it later, and then you can be an adult like me and have it when you're 40 years old. So, I mean,
there
I'd
you go.
rather have it twice as a kid than once
Yeah, exactly.
twice as an adult.
Right, right, absolutely.
Oh my
So
goodness.
very true. Yeah,
Yeah. Yeah. So, and I know, and it's an investment, it's an investment in time and energy and money and all the things. And I do think that people need to realize, like, just like we talked about, like with tongue ties and everything, like it is an investment, but it's an investment in health. And
correct.
I've only seen positives come from, the big investment that I have made across the board. So I'm like, use us as guinea pigs. We have updates on the podcast. You can learn
Right.
about my kids'
And
experience.
yeah, exactly. I tell my kid, everybody, my kid's story for sure. It
Yeah.
was life changing. My younger daughter was not tongue tied, and that's when I was like, oh, breastfeeding shouldn't hurt at all, like not really.
Mhm.
And so that also kind of helped me realize when I got into tongue ties, like, oh, okay, I studied both of their anatomies and all this kind of stuff. But my younger daughter still needed palatal expansion, and she didn't have a frostbite. Luckily, our airway focused orthodontist was on board, and it even changed her smile. She stopped getting ear infections. Like, she was still getting ear infection. Like, she couldn't get her ears to drain properly, well into early elementary school. So all of that factors, and it's not a quick fix for everybody. I realize that, but um, I just go back to it's all about anatomy basics. It's really just that simple.
Yeah. Yeah,
Yeah.
absolutely. Well, and to that point, as a release provider, can you also enlighten everybody on why when I hear people say, "Oh, well, this dentist said we'll just do a quick snip." When I hear that, I go, my antler, like my antennas go up, and I'm like, "No,
Right.
you want to see this provider? Like a quick snip,
Right.
not thing.
Right.
What we want." Can you? And I know we try to educate. Well, you want someone who talks about doing a release, and they talk about the pre and post op therapy, and da 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 da
Yeah.
da da. Any thoughts on that whole quick snip terminology?
In some cases, when it's super anterior, I have had some therapists ask me to do it simply because they can't physically get under the tongue. So there's small number of cases where that makes sense. And then there are a small number of cases where you do see immediate improvement on the latch. It's never full though. Or it's enough to get by with the breastfeeding and everybody's happy and we're good. But then a couple of years later, a lot of them end up having speech issues, for example.
Mm.
So there are a few cases where that might be indicated, but I always educate people. Well, a quick snip does not get the entire tie, the posterior tie. So yeah, for sure. Access to care is also another issue. I'll say that. But for the most part, I feel like people who take it upon themselves to get an evaluation with me kind of know the quick snip is not the way to go, or they went through that already, are still having problems, and now they've been told to come here. So yeah, for
Simple
sure.
math, right?
Right, right. So
So in your area, do you have like a multidisciplinary team that you generally
yes,
work with?
yes, I have a myofunctional therapy who's also a lactation consultant in house, actually, as well as several lactations, uh, OTs, STs, craniosacral. Even we're very lucky in our small little town here to have a good number of people that are into this area and specialize in this area, and then collaborate. And like I said, we have the orthodontist that I refer to that does the early palate expansion as well. So it's really been awesome. And a lot of pediatricians are coming around. We have a good number of them that know this is a thing, and know what to look out for, and they come to our little study clubs and lunch and learns and things like that. So I am grateful for what we have. It's still a work in progress, but it's been great
Yeah.
because it's so important. If you're just the lone provider, you're just running to standstill sometimes with what you're doing.
Yeah.
And I do see it on my patients that unfortunately don't have the access to care. They have somewhat of an improved outcome. And I even say that arguably that therapy is more important than what I do. And I've had some people go in for myo and we don't even have to do the release. Like it's all I say that all the time. Like it doesn't mean we have to do the release ever. Plenty of people don't have to. So it's um it's great to have somebody well, let's try this first. Let's stick with this first, in the area.
Yeah. And that was, thank you, kind of led into my next like thought and question around, what
Yeah.
comes first, the chicken or the egg, the
Right.
therapy or the release or the this or the that. And
Yeah.
obviously, like you kind of shared your stance on that. But I think it's really interesting too, because I know Zoggy talks about this with like the whole
Yeah.
time space issue.
Yeah.
And, sometimes what might appear to be a tongue tie when you actually go through myofunctional therapy and expansion, well, the tongue fits differently in the palate and maybe you don't need that release. And so
Right.
we tend to be like, obviously, the providers we work with will go forward with it when necessary and when we feel like, okay, yes, maybe we'll get more space, but we're pretty sure that this tongue is still going to be restricted. Obviously no one has a crystal ball.
Right.
But in those borderline cases where it's like, I
Yeah.
don't know, I mean, like, let's least invasive option. Let's go with expansion. Let's go with myo.
Right.
That whole tongue space conversation, I think, is happening a little more, but still
Yeah.
not enough.
Right. No, you're so right about that. So, and then there are times where, for whatever reason, and I still can't quite figure it out. I've had some patients be able to tolerate the myo and the release just fine. Because on older kids, I put the sutures, after, and they're able to sit for that awake, but they're not able to tolerate the expander.
Interesting.
So, and it's a chicken and the egg thing for sure as far as that goes. But you know, that's what's great about this. There's the
Yeah.
therapy really helps with the interim as well. We're still getting expansion by getting our tongue up there as much as we can. So,
Yeah. I mean, I always wonder about that too, because as an adult who went into the Vivos DNA, and this is not to knock that appliance, I know it works really well for some people. There was no room for my tongue between those,
yeah,
between the upper and lower appliance. And, sometimes, and, I don't know how you feel about myo brace, but both my kids tried it. It was kind of a fail for both. It was more of a holding pattern kind of
yeah,
tool than anything else.
yeah,
My older one couldn't keep it in. She would gag on it and spit it out within
right.
minutes of sleep. My younger one kept it in all the time, and she was chewing on it and everything the way you're supposed to, and it got a hole and then got moldy. And I was like, well, this is awful. And then I
It
put
was, yeah,
one that we never used.
right,
Anyways, I'm like, why are we filling their mouth with something when they can't breathe? So it's like,
read, right,
I wrap the palatal expander is not going to completely fill their mouth, but also is it putting them into that fight or flight where they're sort of like, I can't function.
Right.
And I think
Possibly. I didn't think about that. You're
yeah,
quite
it
possibly
just
right.
makes me wonder, like having that space, having something in
Yes.
that space, especially as someone right now who has marpers, like it's invasive. And I
It's invasive and it can trigger your gag reflex a lot and,
yeah,
so
working on like trying to get the gag reflex moved to the back of the tongue and trying to do some
right.
things through myotherapy or feeding therapy before the expander goes in, just like desensitization type of therapy. I think, maybe that's it. I don't know. But to your point too, with the foods, like we have a lot of these kids who are, I believe they have these gag reflexes because of the soft food diet and because of the processed foods. And they are not used to chewing, moving things around their mouth. It stays on the side they put it in on, or they're used to
Yep.
mashing things with their tongue against their palate, and it's their foods that break down very easily, and they're not really using that adult like rotary chew, and they're not actually having that sensory motor experience throughout their entire oral
Right.
cavity. And so in goes something new, and it's just like, hold the line. No, thank you. So that's a big conversation right there. But, I also relate with your husband. I have apparently, based on blood work, I can't actually digest the gluten protein. I don't know. No one's ever actually diagnosed me with celiac, and I don't know if that's a diagnostic criteria. I should probably look into that.
Mhm.
When we were in Italy, I was like, I'm just going to eat it because I think it's the other chemicals here, and I ate it and I got really sick. But
Oh, wow.
so that wasn't fun. But I
Yeah.
also kind of came back pretty quickly. So, anyways,
Right.
my younger one has been pulled off of gluten too. She's super gluten sensitive. It also like upsets her tummy now if she reintroduces it, even in Italy. And she's 7. And so I think it's just that for some people, it is so inflammatory
Yep.
that, being off of it, like I just feel like a different human. And I've been
Yep.
off of it for 7 years now, but like,
Yeah.
I feel so much better. It's not even worth,
We're trying.
exploring
Right.
anymore.
Right.
So it's very interesting, the whole
Yeah.
food conversation too.
It is. It really is. And going back to the basics is not always easy because our food has just been so genetically modified at this point and all that. So you try to do what you can otherwise.
Yeah,
So
absolutely.
yeah. Mhm.
Absolutely. So, all right. Well, this has been
Yeah.
amazing. Are there any other thoughts, topics, anything you want to share or discuss before we start to wrap?
If you could have the magic answer to how how we can get insurance companies to pay for my functional therapy, lay it on me. But yeah, that like barriers are my biggest problem. I think
Yeah.
more and more people are becoming on board with the understanding of it all. It's the barriers to care. So
Yeah. I mean, I will tell you in our private practice, because we are private pay, and
yeah,
my team, we do provide super bills, and our families are able to get out of network
yeah,
benefits
we
applied.
do that. We do
Yeah.
that for sure.
Because we're SLPs and SLP OT, we are able to bill it under pediatric feeding therapy because we're doing the
Yeah.
motor work and the
Mhm.
airway that all falls under like that. That's how we're able to do it.
What about for adults? Do you have any
Adults too. It's just
for adults too? Okay.
and there's different codes for like dysphagia, the oral phase of dysphagia.
Okay.
And so it used to be.
Typically for sleep apnea though, like sleep issues. Like let's say they're
We can assign that diagnostic code if it's been given to us by like a dentist, ENT, ortho that's run, certain things, and you guys can diagnose. But we're able to assign that dysphagia diagnosis because the oral phase, which is what we work on as SLPs and OTs and even RDHs, but they can't bill this code, unfortunately.
right.
I think that's probably the biggest issue is we're able to bill oral phase dysphagia, which is what we do in Maya. So for
Okay.
adults, we can bill that. It used to be the same codes across adults and peds, and then they came out with new pediatric dysphagia codes a couple years ago for like acute and chronic.
Okay.
And so we can bill those codes for pediatrics, whereas we bill the typical dysphagia, oral phase dysphagia code for adults
Got it.
for myofunctional therapy, because what we're working on, even when we're addressing airway specifically, is still the oral muscles and that oral, dysfunction. And so it's the patterns, the muscles, the exercises that we're doing that overlaps with what we would bill for neural.
Gotcha.
It's,
Okay.
following issue, which
That's good to
at
know.
that point, it's really the chew bolus prep, which all falls under Mayo.
Gotcha.
So that is how we do it.
Okay.
Yeah.
I'll have to remember that. Yeah, that's another barrier,
Yeah, for sure.
if they're not having a known feeding or known speech issue, but
Yeah.
that's good to know.
Yeah.
Because
Yeah.
it is all related, right? And
Absolutely.
I'm always hoping they'll discover they have a feeding issue that they didn't realize, like, oh, you're not supposed to just eat soft processed foods,
Well, and it's, it's
but
if they were to go for like a MBSS or fees or something, a swallow study, they're not necessarily going to present with a swallow issue in that
correct.
sense. But we break, the swallow for us is built under 3 different levels. And so because we can focus on just the chew and like initiating the swallow up into the point of the swallow starting in the mouth, like chew, bolus prep, getting the food just like moved around the mouth, getting it onto the tongue, getting it ready to swallow.
Gotcha.
That's
Okay.
exactly what we treat in Mayo. And so for us, it's, yes, we can build oral phase dysphagia, but there is no Mayo code, right?
Right.
So, but it is the overlap, because I will tell you that pretty much every adult who's in Mayo is not chewing and prepping their food properly,
Makes
whether
sense.
they identify as having an issue with that or not.
Right.
They got TMJ issues. There's no way they're biting crunchy foods on both sides, right? They're probably biting predominantly on one side. They may be chewing predominantly on one side. We see it in their masseters. There's an asymmetry on their face. So I can look at a face and be like, I know where you chew.
Right. Right.
So they don't recognize it as an issue. It's kind of like with the sleep stuff, where sometimes adults, and I was even this person because I had nasal surgery 3 years ago, where it's like, you don't know what you're missing out on until you know what you're missing out on, right? Like
Yeah.
you have the expansion, you have the nasal surgery, you have whatever the procedure is, and you're like, oh my gosh, I've been walking around for 40 years of my life and I had no idea what I was missing out on. And here we are.
Right.
Yeah. So
Okay.
it's just
Well,
the
that's good to
education
know.
side too.
Yeah. Well, perfect.
Yeah.
To remember all that.
Yeah. Well, awesome. This has been amazing. So where can everybody find you?
I'm located in Lafayette, Louisiana. That's where my practice is. Been a Louisiana native for pretty much since I was 2. My website is LafayettePediatricDentistry.com. And they can shoot me a message on there, anything, just to get in touch if they'd like.
Amazing.
More
Well, we'll be sure
information.
to link that in the show notes so it's easy for them to find you and learn more
Perfect.
about you. So thank you so much for joining
Of
me
course.
today.
Thanks for having me. It's been a pleasure.
Quick disclaimer: all information, content, and material of this podcast are the opinions of the speakers and is for the informational purpose only and not intended to serve as a substitute for the consultation, diagnosis, and/or medical treatment of a qualified healthcare provider.
Thanks for listening to this podcast. If you found value in this episode and want to hear more of these Myotots, Airway, and feeding related episodes, be sure to leave a review on Apple Podcasts and share this episode on your social media platforms. You can access free resources and all I offer at HallieBulkin.com or pop over to @HallieBulkin on Instagram to get all the latest updates.